Okay, we don't have a lot of time for the panel internal discussion, but I do want to bring up a couple of things. First thing is, I think everybody on the panel, including me, has worked both on the ground level and at the 30,000-foot level. So I'd like to at least, and I want to get to 42 CFR in a moment, part two, but for instance, Richard, some of the things you said are very interesting, and but if you were to design, you know, if you had Dr. Crossan's job and had to make rules or recommend rules for Medicare, what are some of the things you would do?
Well, I think some of it was, for me, was taken from the early years of the VA reform under Ken Kaiser. I think what Ken did brilliantly was get people thinking about continuous improvement, but using a very few but highly important set of measures. And I think where the VA has been sort of wandered off the path is you got so many different measures and people are gaming it, and we see the things about, you know, fake waiting lists and things like that. So the point is, as you design a system, I think it is important to measure, but measure the things that are important. The second thing I would say is... Can you give us some examples? Dead's important. Why aren't we using at least risk-adjusted mortality rates for organizations? Isn't that kind of important? Matters to my patients. They ask me about that. I mean, I think it's you know, dead, distressed, disabled, and destitute. Those are sort of four key outcomes from a patient standpoint, right? And I'd much rather focus on those outcomes and leave it to the individual practitioners to figure out how to do better on them, because I think we're trying to do way too much micromanagement, telling people how their process should work. In fact, if I might, there's a model that I actually use that I try to teach our young family docs. I call it the 4 Ps model, at least in terms of our role in the health system. The first P is the patient or the person, and you always want to have as much of the care there, because if people take better care of themselves, they're going to do better. Second P is professional, what we think professionals do. Third P is population, doing active outreach to the 5% that's the high utilizers. And the fourth P, which we often don't talk about, is the public. And I think Mike got at that a little bit with the Camden Project. You have to think of the ecology of the care system that you're in. All those are important. So I give a small anecdote to illustrate this, because again, I've had...
But let's, again, we're writing Medicare law.
Well,
so that's
I'm trying to give you an example, though, in terms of what Medicare might cover.
Okay.
But I'm going to use tobacco because it's the only example I have in my practice experience. So I, for many years, did this program at the elementary school called Tar Wars. It teaches 3rd and 4th graders to avoid tobacco use. And the kids love it. You play games with them. They have to run in place with a straw in their mouth and a pinch thing on their nose and simulate COPD. Personal health care, helping people do the right thing. So about 2 weeks later, I get a call from a young mom saying, "You got to help me quit smoking, Doc." I said, "Julie, this is great. We've been talking about this ever since your daughter was born. What changed?" She said, "Every day for the last 2 weeks, she's been coming home, Mom, doctor says you're going to die if you don't quit smoking. Please quit smoking," right? So that's the second P, professional. I helped her with some medication, some counseling, tobacco cessation. Third P, I'm walking down the clinic about a week after that, and I say, "Hey, Charlie," as I see this guy sitting there with his nasal oxygen in place about to get his flu shot. And I walked about 10 feet, and I stopped, and I turned around and said, "You know, in the last 2 weeks, I've talked to 2 of your family members about tobacco and how important it is to quit. And I said, as somebody that's been affected by tobacco use as you have, I imagine you got strong feelings about this." "Oh, I hate tobacco. Anything I can do to keep young people from smoking." I said, "Well, you can actually do something about that. You're the village president. You can pass an ordinance making Belleville the first municipality in the state of Wisconsin to be smoke-free." And he did. Now, when I tell this story to people that are not family docs, they get a little upset with me. "Oh, you're trying to make the family doc look like the hero." I say, "You don't get it. It was a school teacher that reinforced the message every day. It was the community pharmacist that told the young mom, that nausea you're having with the medicine, it'll go away. It was my office nurse that ran the registry that brought in the high-risk populations for their flu shots. And it was my practice receptionist that kept showing up at the council meetings until they finally passed a damn ordinance." Here's the thing I would say to Medicare. Figure out a way to incent me to do that.
So what would you suggest?
Well, I think one of the ways is you can do it through blended payment models, where you pay me a portion of what I get through capitated approach, because I'm taking care of a population. Some of it you want to do fee for service, because that makes me run faster. You make me do things that you want me doing more of. And some of it I have no problems with pay for performance on top of that in terms of how you structure payment. It's just that I don't want the incentive for that to be too big. I think probably 10%. What I've seen in other countries like Norway is that's what they've done. So, for example, in Norway, they were having a hard time getting young parents to allow their children to have pertussis immunization. So they paid the GPs 4 times more for pertussis immunization than they were getting before. Guess what happened to pertussis immunization rates? Because the doc was willing to take the time to sit down and really have that conversation. So the system that you build, both by incentives and by structure, is a system you're going to get. And that's where I
think that brings up an interesting point about standardization and non-standardization. Some things can be incentivized greatly by money, others can't. And I think we have to certainly have to take that into account. I want to get to 42 CFR Part 2. There's two things that occur to me. One is the book entitled 3 Felonies a Day. And that is, we all break law. There's these laws, we don't even know about them, or they're so silly, we break them every day, except that someday somebody may put us in jail or fine us heavily, like could happen with 42 CFR Part 2. Secondly is what you brought up. It's this balance between, and this is, every privacy issue is like this, between the rights of the individual to privacy and whatever we want to do, whether it's fight terrorism, whether it's take care of genetic information, whether it's that. So my question is, where do you consider that sweet spot in this more specifically, perhaps? Where should it be for substance abuse so that the person does not lose their job or go to jail just for seeing a doctor? On the other hand, that we can communicate the information to take care of the patient.
So I think the statute is actually a good place to start. The Part 2 statute is not that complicated. And it basically says patients have to sign consent. It doesn't say the form of consent. It doesn't, you know, I mean, it was written in a time when there was not electronic transfer of data. I think that we've built rules over the years that address specific issues in the point in time that we wrote them, and then we've added new rules to them, right? So the rules are very complex now. So I think the sweet spot is, you know, if I were queen of the world and had a magic wand, is that that patients have the right to decide, and perhaps not just with their substance abuse information, but any of their information, that we have the technology to do data segmentation, because we do have that technology, and that we have a healthcare delivery system that is patient-centered, so that people are comfortable having information shared, and that it only lives in the healthcare system.
Okay, so that's protected too. I mean, the healthcare system is protected from loss of information. Is another important aspect, right? In other words, so there are no breaks in the information.
Oh, I see what you're saying.
I mean, they have to trust that their information is going to be kept confidential,
exactly,
and that somebody else won't be able to get it for whatever reason.
Right.
Okay. Do you, as far as underserved areas, personnel turnover is a big issue. Let me just rephrase. What do you think? I mean, in underserved areas, there is more to do. There is less money to do it. Personnel turnover is a big issue. There are many other factors that may be helpful to our consideration of the healthcare system in general, if we look at what happens there, because they're more intense and concentrated. What do you think we can learn from looking at underserved areas, particularly rural areas? What do you think, Richard, that we can, let's say, rural medicine?
Well, I think what makes it a little easier to come to conclusions in a rural setting is that the relative geographic isolation means that we're all in this together. My very first night on call in this isolated community, one of my partners told me about a patient. He was signing off to me that he had admitted the night before, and this was a young man with a heart attack. And as he was talking about the patient, it was clear he'd never come in to examine the guy in the middle of the night with a heart attack. I'm just in this community, I'm thinking, what have I gotten myself into here? And I said, you never saw him? He said, oh, no, Mary Jane was on last night. She was a critical care nurse for years. She knows way more about reading EKGs and stuff than I do. If she was going to have a problem, she'd have let me know. So one of the things you learn in a rural community is it ain't about pedigree, it's about performance. Because you have to have top of the license is a bogus term to me. It's people working at the top of their capacity. And you see that more easily in a rural setting. It really does come down to the people that are doing it.
Do you have anything to add? And not maybe about rural or...
Actually, no, I think, and I'm going to use some of the Dartmouth work we've done. I mean, I think that and Richard sort of teed this up before as well, which is that sort of an academic paper that my dad and I wrote in BMJ about 4 years ago was looking at risk adjustment. And this is actually something I'd love CMS to take on, which they won't because it's too politically hot. But there's this risk adjustment HCC score that is being used, which is basically a measure of the intensity of services delivered by the practice physicians and not of the risk of the health of the patient. Jay, you can come back at me later on. But what we did find is, that there were sort of three public health measures which were critically important to overall survival, coming back to the dead question, Richard, that you had before, which was smoking, obesity, and connectedness. I mean, people being able to have somebody they can talk to when they do, which is a weird concept, but it explains 70% of the variance in the Medicare population, where the HCCs basically explain 2% of the variance, or actually 10% of the variance. The reason I actually bring that up is that these are things that doctors don't actually have to do. In fact, if you look at the most effective smoking cessation programs and obesity programs, they may have been teed up by the trusted relationship with a physician, but quite honestly, it's somebody else who is practicing intensive motivational interviewing and other types of CBT type of work that gets that to it. And so I actually don't think it's just a rural issue. I mean, I think it helps in the rural issue because there's no doctors there to mess it up, and so somebody else has to take it on. But that actually thought about the idea, I think, is an important piece that it goes beyond the traditional rural area. A lot of the things that make a big difference in terms of long-term survival and functional status are not things that we traditionally do within the doctor's office. They're actually things that are much more about personal ability to manage complex issues like smoking, addiction, other types of addiction, et cetera. You didn't ask me this before, but I actually would like to come back to the 42 CFR question as well. Sure. I'll give you a real-life example of how the workaround around 42 CFR. So one of the theories of integrated care is that mental health providers and physical health providers are actually working together on behalf of the patient to get them better, obviously with the patient at the center of that. I say that obviously, but that's actually not necessarily always true. We do have this sticky thing called 42 CFR, which we get lots and lots of data from various sources, which we are not allowed to use because we're trying to stay out of jail. But not just that, but we also want to observe, we want to maintain the privacy of the patients to opt into the data sharing piece. But you also have this sort of conundrum then, is that people who are getting access, and it's not just for substance use disorder, are basically getting episodic care, often not very systematized. And you see people going in and out of repetitive therapies, and a lot of it's not because they aren't following the regimen, it's because the regimen is actually not very good. And you'd like to be able to tee up the provider to the primary care physician that there's an issue here, that repetitive therapy, and that there are alternative methods of treatment which are more evidence-based, and you can help refer to that. So our workaround, Kimberly, and you can tell me whether we're doing this right or not, is basically teeing up the opportunity to ask the patient about their general mental health. So we basically know that they've been in and out. We suppress that information when we tee up an at-risk patient, if you will. But we basically tee up the conversation and then support that conversation with standardized instruments, one of which is the substance use questions, which allow both the trusted relationship of the primary care physician to bring that up, and as part of the routine practice, ask the hard questions that are actually create, whether they lie or not, actually, that we can come back to that. Most is that they actually give the opportunity for the patients to quantify in a trusted relationship their exposure. So we don't run afoul of 42 CFR, but we do identify somebody as at risk. Now you can tell me how well that we're doing on the statutory side, but it's actually been a very helpful workaround. I mean, primary care physicians often don't know. I mean, many primary care physicians are not as close to their patients. And even in the anecdote Richard talked about, he knew about the person needing support again, not because of the patient, but because of the maternal grandmother. And so an ability to actually work around that, I think, is critical. That was too long. Sorry, Joel.
Yeah, no, that's okay. Kimberly, so let me ask you two questions. One is, will the new law help in this workaround? And secondly, how often have the penalties been applied under 42 CFR?
Never.
Okay.
Never.
Which was my
So
first
there's
point
that-
about 3
I've answered
felonies a day.
the second question. It's never actually, the way it's written makes it, there's no individual right of action. So basically, the federal government has to take the action, and it never has chosen to do that. So I'm not an attorney, and I don't give legal advice in my current role.
I wouldn't ask you.
But,
won't consider it
but
advice.
the current regulations, I mean, obviously what we were trying to do in the revisions and in the new revisions that will hopefully be coming out very, very, very soon, is to address this issue of electronic transfer of information. And so all of the changes that we made were designed to address that. And the current revisions that we're hoping to release before the end of the calendar year are addressing this whole issue of the use of contractors and subcontractors and other kinds of organizations to do all of this work that used to be done by a single organization. So we're definitely trying to modernize it without eliminating it. The one thing I would say about what you guys are doing is Part 2, right now, the way the regulations are written, only applies to specific programs that meet specific criteria. And so if you're in a primary care practice or in a general medical practice, and you diagnose or identify under the current regulations, you wouldn't fall under Part 2.
You know, whether this applies or not, one of the problems in workarounds is that we follow rules that don't exist, that somebody says there's a rule, and, we take their word, but it really doesn't.
Right.
No, I think the issue we came up with, Kimberly, is that because we have access to all sites of care, it is the facility-based specific treatments that we have to suppress the care in. That's the workaround on that side, and that's actually, but coming back and why we think we're, and as you said, is it's not a primary care issue, is that basically making that conversation easier to happen in the primary care setting, sort of, it's not a workaround, actually, it's just the right thing to do anything.
It's the right thing to do, right,
So,
everyone should be doing that.
Okay, we won't put you in jail, it's okay.
There may be other reasons for that to happen.
Yeah, we'll find one. I just want to mention something, Richard, that one of the VA success stories, I headed the VA research program for 8 years, was influenza immunization. And what they did, and this is partly through their ECRI program, which is a research implementation program, is they got, and something along the lines of what you said, they got everybody involved. It wasn't just physicians, it wasn't just nurses, it was people at the front desk, it was people on the telephone, it was just everybody who ever saw the patient, ever spoke to the patient, got involved with encouraging immunizations, and they increased it tremendously. I mean, the numbers are very impressive. So that does make, I think you made that point before. Okay, I hope there's somebody out there. I'm a little nearsighted, so I don't see anybody. Come on, somebody must have a, begin Q&A, that says. There, we got a question.
I always have a question.
Yeah, good.
Doctor, you were working with people with substance abuse. You talk about the 5%. A lot of those people are self-medicating themselves, be it with alcohol or marijuana or street drugs, because they can't afford the services or they don't trust the doctors. And that distrust came from the pharmaceutical industry, who have tainted the industry with greed. And it's funny because the FDA director told me to stay away from this question, so sorry, I'm not. The U.S. government owned, I know, Stacy's trouble. The U.S. government owns the patent to cannabis cures, and they've owned that patent since 2003. And they are still jailing people for using the medication, and they say that it has no medical value. But how can it have no medical value when you have the patent for it having medical value? And how can you get it to the forefront? Because a lot of people are benefiting from the drug, be it from AIDS or HIV or seizures or ADHD or autism or PTSD. You know, we've got 22 soldiers and one veteran, 22 veterans and one soldier, who commit suicide every day. And in Israel, they give their soldiers cannabis oil because it's safer than the meds that they're giving them. And I know this because we have funded those studies, the taxpayers, and that money has come from NIH and given to Israel to do the studies. So the studies have been done. What are we doing to give the American people that choice? Because aren't they protected by the 9th and the 10th Amendment? Lawyer?
We have one lawyer on the panel, right?
Yeah, well, the quick answer is no. I think the issue around cannabis is an interesting one, and you know, I'm always reminded of Osler's admonition that all new treatments work wonders at first, and I think that's kind of what we're going through with cannabis right now. I think it's going to be fascinating to see in the states that have legalized it, both for medical and recreational purposes, to see if they have a difference in opioid dependence or abuse rates and how good or poor a job those states are doing relative to chronic pain. I mean, my big issue around a lot of what's happening today in substance abuse, especially opioids, is if the admonition to primary care docs is give less, my response is great, love to. What do you have as an alternative? It doesn't exist. Where I am, you can get oxycodone covered by insurance. They can't afford the gas money to go 45 minutes up the road to see the psychotherapist that runs a pain clinic. They literally can't afford it. So it's, you live in an imperfect world as a clinician, we all do, and I think our challenge is finding suitable, better alternatives for many of these things. And I don't consider myself a cannabis expert, and I'll turn to two people who probably are.
Any other comments?
I meant that in a professional sense.
I'm an expert in dodging the question, but I'm not an expert in cannabis.
Yeah, I don't know what I want to say about U.S. policy on cannabis. It's actually not even a political issue. It's been the same no matter who's been in charge.
I think it's actually sort of done. I'm going to be a little bit flippant, but
States.
if you look at what the states have done, it's sort of like, I think the question that Richard brought up is exactly right. I actually think that the whole issue about legalization and non-legalization is happening state by state, and
But there's a special issue. You mentioned veterans. There's a special issue in the VA about it.
Oh, there's special issues there's special issues everywhere, Joel. I'm not trying to be flippant about it.
But this, because of veterans and the treatment of PTSD, there's a special issue about cannabis use in the VA.
Yeah.
That's what I'm saying.
Yeah, no,
and I think there's another point about this too. Ecstasy now is on the fast track for study for PTSD, and I think I agree. I think we have to be careful because it's.
Richard.
Okay, Jeff.
Yeah, I have a question again about the drug area. With a lot of people with substance use disorders, they don't admit to having them. And yet, a healthcare system should be able to deal with people who don't acknowledge their problem, because their problem is a problem. I mean, you only have to look at the number of drug deaths, the 65,000 a year. And so, is there a workaround that can help us with that issue? Or is it just, hey, that's the way it goes?
Well, so I guess I'll address that. Victor Kaposia would have told you that nobody diagnoses themselves with diabetes either. You have to ask the questions and give the diagnosis. And so one thing that we don't do is ask the questions often enough in other than specialty care settings. But people that have serious substance use disorders frequently don't show up in the healthcare system. And so one of the things that we've been working with the states who just got this $1 billion to do is what we have done in the past with other kinds of mostly infectious disease, which is active outreach and engagement in care. So we did this with HIV, we've done it with other infectious disease where, in the early days of HIV, I was running a program where we had the street workers with the backpacks and the vials of bleach and the condoms, and they went to the places where people hung out and handed those things out. And so we're now working with states to identify those areas of high need, and to do something very similar to that, to send people, whether they're community health workers, peers, to go out into the community. It might be the emergency department, that's very popular right now, but it also might be, places where people are using, and to do harm reduction kinds of things, make sure they have naloxone, make sure that they are aware of needle exchange, but to also try to have that conversation about, wouldn't you like to get into treatment? Now, the trick about that, and the hardest part of it, is when someone says, yes, I do, the treatment has to be there. You can't be put on a waiting list. And so the hardest part right now is not the outreach, it's the making sure when the person says yes, they actually get care.
Yeah, I would echo Kimberly's question. I think, and it's very critical in the substance use issue, but it's the same thing with depression and anxiety. And it is a challenge to get. The supply side is really a challenge in what I would call good MAT. I mean, really good therapy. And I don't think we're a long way away from being able to fix that. I do think, though, that to Jeff's question on I've been remarkably surprised about how people actually fill out the standardized instruments if you ask them to do it. And so I actually don't think I think it's less a barrier of people talking about it and doing it, and it's more a barrier of being able to figure out how in a systematic way you can ask the question. I mean, we have a crazy assessment tool, which is basically the PHQ audit and GAD and audits with a screening and then branching if you positive, and then you flip back around and you do the GAD, and then you flip around and you do the audit. And we get a 92% completion rate. So it's not people not willing to do the assessment. It's the right setting to ask them, which is the primary care setting, teeing up the question. And then a really simple way of getting that done. Now, you shouldn't do that if you don't have somebody to catch on the other side, which is, so the quid pro quo we have on that perspective is we don't start encouraging primary care physicians to start doing the routine screening until we've got identified providers who will be able to catch the ball on the other side. And that's just part of the knitting together from this crazy chaotic system that we have. That's a lot of work to get that done.
And I think the word maybe is trust. Trust of the system, trust of the individual physician.
Never trust a system.
Well, that's the point, and that's why it doesn't happen.
Well, can I raise one more issue with this? David, you were kind enough at the beginning of your talk to reference one of the reasons we wanted to put this panel together, which was to see if we could use this concept of underserved populations in a very different way than people normally do. It's normally divided, along economic or racial or ethnic lines, lots of other social determinants of health, but rarely is it used for mental health or substance abuse as a category. And I'm wondering what you think of the policy implications of using this definition. Because after all, in some other areas, by using it, it's stimulated creating those services.
Yeah, Jeff, I think that's quite a profound question. I think that what I think about where we are right now, and it's definitely not where we want to be, but I do think that there is important movements, both societal, people, organization, as well as payment that has happened. Patrick Kennedy is on our board, and he was one of the key sponsors of the Mental Health and Substance Use, which they always drop the second part of that, Parity Act. It is law. It's still not universally followed. But I will tell you, even in the 2 years that I've been with Quartet, I'll tell you one of the things that has changed a lot about that is that patients who used to pay out of pocket because people weren't accepting insurance are now asking their providers, basically, I have this insurance, it says I have these level of things, why aren't you doing this for me? And so we've actually found in just 2 years, a pretty big uptick in the mental health providers, both on the substance use side, but also on just LSCSWs and psychologists who are now accepting insurance, mostly because their clients, as they call them, are demanding that they have that because they've got a benefit, and why would they pay for something out of pocket when they've got already paying for it on the insurance side? So I do think that there are important policy pieces, and I see the Mental Health Parity and Substance Use Parity Act as actually an important push. We've got a long ways to go from that perspective. But like cannabis, and like actually stigma around mental health, is that what I think is very different now is that everybody under 30 talks about their mental health provider issues. They're like completely open. We talk about it's like they all talk about it. They're actually telling their parents to talk about it, and we have the insurance side that's happening on the side. So I think there's an interesting twofold efforts that are going on, and things that are going on right now that I think are going to be important, and not that it's the same. But I do think the Parity Act and its full implementation, which is still a ways to go, and then the other issue is a general acceptance, destigmatization, and therefore a more vocal consumer who's demanding more access to the services, which I think are going to help us a lot from that perspective.
Thanks.
Could I just tack on to that? Is there, though, some benefit in changing legal definitions concerning underserved areas to include something like that? Do you see that at all?
Yeah, I think in the primary care world, using geographic designations for underserved has been quite helpful. It's helped move people out there, and I know that there are similar, like educational loan repayment programs in the mental health substance abuse world, but probably not enough or big enough. If I might just add on to briefly to what Kim and David had just said, the challenge for me around the interface between mental health and physical health, if I can use that term, because in my world, I just take care of people. I'm a simple country doc, and you come with your emotions, you come with your physical ailments, and I'm just going to take care of you. And what happens that I find really challenging around the access issue is I've had people that I've literally been on the phone every night for 30 days in a row because there's nothing else out there for them. And finally, by the time they get to the psychiatrist, it's like, the game's over. I mean, you got the easy part. Let me give you the handoff now, right? So that's a huge issue, is just having adequate numbers of well-qualified and available people. And if we can do it through telehealth strategies, hey, whatever it takes. The second thing I want to emphasize, just so my earlier remarks aren't misconstrued, is I can't do this alone, and I never have. I've always had wonderful people that I work with on my team. And so it's not that I'm anti-team, it's that I'm trying to say that from the patient's point of view, the person's point of view, you got to keep it small, manageable, and fairly consistent and reliable. Because it's often this, I had a therapist for 6 weeks, and then she was on maternity leave, and then the next one went on vacation, and then the next one left the practice, and I mean, talk about trying to, do everything you can to explode trust. Those are the realities of what's going on out there. So somehow we've got to build incentives, financial or otherwise, that really make these kind of jobs sufficiently attractive that people will stay and do what they need to do to help the folks we're trying to help.
Final comments, any? No? Okay, thank you.
I won't keep you, but I'd like to see you tomorrow.